So, Mr. Thompson, can you tell me about your headache?
It's a throbbing, pulsating sensation, almost always on the right side of my head. It starts as a dull ache, and then over an hour or two just builds into something, well, incapacitating. The pain gets so bad I have to go lie down in a dark, quiet room until it passes.
As the intern continued the questioning, the professor stood in the corner, arms crossed, observing in silence. His gaze was intense, analytical. He watched not just the patient, but the intern.
I also get nauseous, and the bright screen at work or just normal office noise becomes unbearable. Sometimes before the pain starts, I see these weird shimmering lights, like zigzagging lines of electricity in my vision.
The intern dutifully jotted down the notes. Throbbing pain, right side, nausea, sensitivity to light and sound, visual disturbances. He felt a small surge of confidence. The symptoms seemed to fit a pattern he recognized.
The intern. Now, walk me through your clinical reasoning. What's the most critical diagnosis you're ruling out with this headache history, and why?
Sir, based on the unilateral throbbing nature of the pain, combined with the photophobia and phonophobia, it seems like a clear case of a tension-type headache. They're, very common, and the stress of his job as a software architect likely contributes. The visual disturbances could be an atypical feature, maybe related to eye strain from looking at a screen all day.
A heavy silence descended upon the room. It was thick and uncomfortable. Mr. Thompson looked from the intern to the professor, a flicker of confusion on his face. The professor's expression did not change, but a dangerous stillness settled over him. The intern felt a hot flush of panic creep up his neck. He knew instantly that he had made a grave error. The silence stretched on, each second amplifying his mistake. The professor finally broke the silence. His voice was low, but it cut through the room like a sharp sword.
A tension headache?
He repeated, the words dripping with sarcasm.
Dr. Meyer, are you even listening to the patient, or are you just ticking boxes on a form? A man comes to a specialized neurology clinic, describes classic neurological aura, incapacitating unilateral pain, and severe associated symptoms. And your brilliant conclusion is tension headache? Did you leave your brain in the locker room this morning? Or perhaps you believe the textbooks are merely suggestions to be ignored at your leisure.
The intern stood frozen, his face burning with shame. He could feel Mr. Thompson's eyes on him, a mixture of pity and alarm.
You ignored the single most important diagnostic clue the patient gave you, the visual aura, a scintillating scotoma. He literally painted a picture of a classic migraine with aura for you, and you dismissed it as eye strain. It is an act of profound intellectual laziness.
The professor was relentless. He saw this not just as a mistake, but as a moral failing, a betrayal of the patient's trust.
Medicine is not about finding the easiest answer, Dr. Meyer. It is about finding the right one. You have done a disservice to Mr. Thompson by minimizing his suffering with a trivial diagnosis. If you cannot differentiate between a common tension headache and a classic migraine with aura, you have no business being in this room.
Humiliated, the intern retreated to the corner of the room, his notebook clutched in his hand like a useless shield. The professor's words were brutal, designed to dismantle his confidence completely. It was a harsh and maybe even cruel method of teaching, but it was the professor's way. The professor then turned his attention to Dr. Carter, the senior resident. His tone softened, but only slightly.
Dr. Carter, enlighten us. Provide a diagnosis that is grounded in the evidence presented by the patient, not in a fantasy of simplicity, and explain to Mr. Thompson what is actually happening to him.
The challenge was clear. She was to correct the intern's mistake, educate the patient, and demonstrate her superior clinical acumen all at once. The pressure shifted from the humiliated intern to the composed resident, who met the professor's gaze without flinching.
Mr. Thompson, I'm very sorry for the confusion. What you have described is not a simple tension headache. The collection of your symptoms, the visual disturbances that precede the pain, the one-sided throbbing quality of the headache, the nausea, and the extreme sensitivity to light and sound points very clearly to a diagnosis of migraine with aura. The visual changes you see, the zigzagging lights, are what we call a scintillating scotoma. This is the aura phase of the migraine. It's a neurological event caused by a wave of electrical activity spreading across the surface of your brain, specifically the visual cortex at the back of your head. This wave is then followed by a period of reduced activity, which triggers the headache itself by irritating nerves and blood vessels. It's a complex brain event, not just a muscular tension issue in your head or neck.
The professor listened intently, a flicker of approval in his eyes. Dr. Carter has not only identified the correct diagnosis, but had also begun to explain the underlying pathophysiology in a way the patient could grasp. She had restored order and competence to the consultation.
The fact that the headache is so severe that it incapacitates you, forcing you to lie down in a dark room, is also a hallmark of migraine. The International Headache Society has very specific criteria for this diagnosis, and your story fits them perfectly. You are not imagining it, and it is certainly not just stress.
Her words were a balm countering the dismissal the patient had felt just moments before. Mr. Thompson listened intently to Dr. Carter's explanation. For the first time, he felt a sense of relief. The diagnosis of migraine with aura felt right. But this was just the beginning. He needed to understand what it meant for his life and his health.
A migraine, huh? I always thought that was just a really bad headache, but this wave in my brain you mentioned, is it dangerous? Is it like a stroke?
This was a critical moment in the consultation. The patient's fear was palpable.
That's an excellent question, Mr. Thompson, and a very important one. It's true that the aura phase involves changes in brain activity, but it is not a stroke. In a stroke, brain cells are deprived of oxygen and begin to die. The migraine aura is a temporary, fully reversible event. The brain cells are just misfiring for a short period and then they return to normal.
Mr. Thompson seemed to relax slightly but pressed on with another concern.
So if it's a brain event, does this mean I'm at risk for other neurological problems, like epilepsy or a brain tumor? I have to admit, that's what I was most worried about.
It's completely understandable that you would worry about that. However, a classic migraine with aura, like what you're describing, is not typically associated with a brain tumor. The pattern is very characteristic of migraine. While we might consider getting an MRI scan just to be absolutely certain and to provide you with complete peace of mind, your clinical history is very strong for a primary headache disorder. This means the headache itself is the problem, not a symptom of another underlying disease. It is a condition of the brain, not damage to the brain.
With the patient's most urgent concern addressed, the professor moved on to a more detailed explanation of the condition itself. He had laid out a clear, hopeful path forward, transforming a frightening condition into a manageable one.
Let's talk about what a migraine is. Migraine is a brain disorder, not a vascular problem. Think of it as having a migraine brain, meaning your brain is genetically predisposed to be more sensitive to changes in your environment. For people without migraines, things like a sleepless night, a skipped meal, or a stressful day might just make them feel tired. For you, those same things can act as triggers that push your sensitive brain over a threshold and initiate that wave of electrical activity we talked about, starting the migraine attack. Irregular sleep, even certain foods like aged cheese, chocolate, alcohol, or caffeine, or even a weather changes can push your sensitive brain over a threshold. Part of managing migraines is becoming a detective. I recommend you keep a headache diary to track your attacks and what is happening in the 24 hours before they started. This can help us identify patterns and give you more control. There are two ways we treat migraines. First, there is acute treatment. This is what you take when you feel a headache coming on to stop it in its tracks. For migraines, simple painkillers like ibuprofen or acetaminophen often fail.
So I take these when the aura hits?
Yes. Second, preventive treatment, like beta blockers like propranolol or CGRP antibodies, to reduce your migraine frequency. Our goal is to find a treatment plan that gives you your life back, reducing the number of headache days you have each month.
Thank you, doctor. You've explained it better than anything I've read online. I feel like I finally understand what's been happening to me.
He shakes the professor's hand warmly, nods to the team and leaves with prescriptions. The door clicks shut.
Good. Dr. Carter, you correctly identified the diagnosis, explained the pathophysiology, addressed the patient's concern. Dr. Meyer, for you, let today be a lesson. The patient will almost always give you the diagnosis, but only if you are willing to hear the story in its entirety. Now, recite the 5 criteria for migraine with aura.
The intern stepped forward, his voice still trembling slightly, but he recited the criteria perfectly, the words now seared into his memory by the heat of his earlier humiliation. The professor listened without interruption, and he's impressed this time. The clinic day would continue. More patients were waiting. A patient had been helped, a resident has excelled, and an intern, through a painful but effective lesson, had learned something in Menla Clinic he would carry with him for the rest of his career. Thank you for joining us till the end. Like what you see? Don't miss out! Hit the subscribe button below and turn on notifications for such awesome videos every week.